And radiosanitizers Part 2. Bioreductive drugs. These agents are non-toxic to cells under normal oxygenated conditions. When reduced intracellularly, form cytotoxic agents. Bioreduction is favored under hypoxic conditions due to cytochrome P450 and DT diaphorase reductases. The efficiency of bioreductive drugs may be increased further by inducing increased hypoxia in tumors through the use of vasoactive drugs such as hydralazine. This induces vasodilation in normal tissues, thus diverting blood from tumor. Bioreductive drugs can be divided into three groups: quinones, nitroaromatics, organic nitroxides. Specific examples of bioreductive drugs: mitomycin C, tirapazamine. The former is an anti-tumor antibiotic that is bioreduced to form products that cross-link DNA. It is cell cycle non-specific, is more toxic to hypoxic than aerated cells, is usually administered IV, and is rapidly cleared from plasma. The drug does not cross blood-brain barrier, and major toxicity is myelosuppression. Indoloquinone EO9 is a synthetic analog of mitomycin C, which was expected to have similar properties to MMC, but fundamental differences have emerged. EO9 is a much better substrate for DT diaphorase, and it has the ability to redox cycle more readily than MMC after reduction by purified DTD. EO9 has ability to increase cytotoxicity to hypoxic cells 49 for lower MMC. The overall capacity of tumor to metabolize EO9 has been suggested to be the most important determinant for EO9 activity. This, along with the rapid clearance of EO9 in humans, has been suggested as one of the reasons for disappointing results obtained from phase 2 clinical trials. A more promising group of bioreductive drugs is organic nitroxide, of which tirapazamine is the most widely known. It is true that some of the failure to demonstrate clinical benefit in phase 3 trials may reflect the need to better identify patient populations with high level of tumor hypoxia. In addition, there is a excessive metabolic consumption as it penetrates extravascular space, so that its apparently impressive selectivity for hypoxic cells from 50 to 300 folds in vitro dimensions to a more modest range of 3 to 5 fold in vivo. Vascular disrupting agents alter tumor blood flow via activity on the colchicine binding site on tubulin, leading to changes in endothelial cell shapes and increased vascular permeability. New radiosanitizing agents, example bevacizumab, a humanized monoclonal antibody specific for vascular endothelial growth factor 3. Drugs that target hypoxia-induced proteins, example immunomodulating drugs. Concurrent chemotherapy. This involves synchronous use of chemotherapy and radiotherapy. Squamous head and neck cancer show a clinical response to a number of chemotherapeutic agents, so the strategy of combining such drugs with radiotherapy seems justifiable. Many randomized trials have been conducted in which a combination of chemotherapy and radiotherapy have been compared with radiotherapy alone. This has convincingly shown that addition of chemotherapy, standardly cisplatin, does give better results than those achieved with radiotherapy alone, and confirmed with longer followed up and later studies. The counter argument has been made that the same could be achieved by simply giving more radiotherapy. However, it is known that beyond a certain level, the incidence of complications rises rapidly if additional radiotherapy is given, which is why the doses used in common practice are as they are. Neoadjuvant chemotherapy. Neoadjuvant or induction chemotherapy is the use of chemotherapy prior to definitive surgery or radiotherapy in patients with locally advanced disease. The intention is to reduce the tumor bulk before definitive treatment and hence improve local and distant control of disease. This will also achieve greater organ preservation and overall survival. Combined chemotherapy and radiotherapy schedules have been tested in randomized controlled trials against a policy of primary surgery for moderately advanced laryngeal and hypopharyngeal cancers. Such organ preservation represents a significant advance in radiotherapy of head and neck cancer and continues to attract a great deal of attention, with trials of different drug or radiation schedules and involving other head and neck sites. However, there is still no proven benefit in providing chemotherapy prior to definitive chemoradiotherapy. In fact, in these trials, the drug has been given before radiotherapy, so are certainly not acting as true radiosanitizers but are mentioned here for completeness. They have been shown to be no less effective than radical surgery in terms of survival, but confer the advantage of enabling preservation of a functioning larynx in a substantial number of patients. Targeted chemotherapies. These drugs act against cancer cells in a more targeted way than the cytotoxic agents that have been the mainstay of chemotherapy in the past. Because of their specificity, such agents are much less toxic than conventional chemotherapy. In head and neck cancer, one target has so far attracted significant attention: the epidermal growth factor receptor (EGFR). This is one of a family of transmembrane receptor tyrosine kinases, other membrane being HER2, HER3 and HER4. Ligand binding receptor dimerization occurs, which induces a conformational change in intracellular kinase domain, thereby inducing a cascade of phosphorylation events or activation of signal translation. Example: activation of MAPK or RAS signal transduction pathway, as implied by its name and as might be expected in a tumor arising from squamous epithelium. Overexpression of this receptor is a very frequent event in head and neck squamous carcinomas and carries with it a worse prognosis. Its overexpression, with or without gene amplification, is often associated with increased production of EGFR ligand, particularly epidermal growth factor and transforming growth factor alpha. Selective compounds have been developed that target either extracellular ligand binding region of the EGFR or intracellular tyrosine kinase region. The first of these target the extracellular ligand binding domain using a monoclonal antibody approach. Cetuximab is a chimeric humanized monoclonal antibody that competitively binds to EGFR. It has a higher affinity for EGFR than TGF alpha and EGF. Once bound to the receptor, the complex is internalized and the receptor thereby rendered inactive. Cetuximab in head and neck cancer used both as monotherapy and as combined therapy. Cetuximab may, in addition to exerting anti-proliferative effects by inhibiting the MAPK signal transduction pathway, act as an anti-angiogenic agent and therefore exert radiosensitizing effects via mechanism described above. Despite these impressive results, concurrent chemotherapy using cisplatin remains the gold standard for locally advanced head and neck cancer unless renal function precludes the administration of platinum. The second approach available to target receptor tyrosine kinases via the use of small molecules that compete for ATP binding site of this kinase domain. Low molecular weight of these molecules may allow them to penetrate tumors better, and they can be administered orally, making them suitable for chronic therapy. Several agents, including gefitinib and erlotinib, show promise in clinical trials as monotherapy 27-28 and in combination with standard chemotherapy. Unfortunately, these anticipated benefits do not appear to have been translated into studies with radiotherapy 29.